Hello, everyone. Welcome to your lecture on the disorders of the liver and the pancreas. Here are the learning objectives for this lesson. So let's start with cholelithiasis, right? Gallstones, basically. This refers to the formation of gallstones or calculi, which develop within the gallbladder or the bile ducts when components like cholesterol or bilirubin become overly concentrated or thick, right? Or when there is a deficit of bile salts. Now, this process begins when basically a focus or a nucleus forms, often due to infection or inflammation. This causes the solutes to deposit and grow into the stones. The process which is exacerbated by sluggish bile flow. We primarily see two types. We have cholesterol stones, which are twice as common in women and linked to obesity and high estrogen levels, and bilirubin stones. These are more frequent in those with hemolytic anemia or cirrhosis. Now, while many stones remain silent or asymptomatic, basically, they cause significant distress when they obstruct the bile flow. This can lead to biliary colic, right? The blocking of the flow characterized by sudden, severe waves of pain in the upper right quadrant or the epigastric area, which often radiates to the back and the right shoulder, which are hallmark signs of, gallstones. Typically happens after a fatty meal. So if you eat something with a lot of fat, people notice that pain. If the obstruction continues, it can lead to cholecystitis, which is manifested by fever, nausea, jaundice, because now the bile is backing up into the liver. Now, to confirm a diagnosis, ultrasound remains the primary tool for visualizing the stones, and CT scans can also be used, or blood tests for elevated bilirubin levels. Treatment most commonly involves laparoscopic surgery to remove the gallbladder and the stones, though some patients may be candidates for like lithotripsy, sorry. This to basically break the stones, fragment the stones with sound waves or pharmacological therapies, basically to dissolve these stones. Now let's talk about hepatitis. This is basically the inflammation of the liver. This can happen from viral infections, toxic chemicals, or systemic diseases. Pathophysiologically, the liver cells are damaged either by direct action of a virus or cell-mediated immune response, leading to necrosis of the hepatocytes and swelling. This can obstruct blood flow, basically blood and bile flow. This condition is known as biliary stasis. Now, even though the liver has excellent regenerative powers, chronic inflammation, especially from like hepatitis B, C, or D, can result in permanent fibrous scarring and cirrhosis. Now, clinically acute hepatitis progresses through three distinct stages. You have the pre-icteric stage, marked by insidious fatigue and nausea. The icteric stage, basically characterized by jaundice, dark urine, and enlarged tender liver. And then finally, the post-icteric or recovery stage, where symptoms gradually subside. Now, to confirm a diagnosis, we usually look for elevated liver enzymes, such as the AST and the ALT, specific viral markers, and increased bilirubin levels. Because there is no direct medical cure to destroy the virus itself, treatment is basically primarily, I should say, supportive. It focuses on rest and high protein diets to aid the regeneration of the liver. Through chronic cases, even though chronic cases may require antivirals or interferon, prevention remains critical through the use of vaccines for hepatitis A and B. If left unmanaged, the complications from it can be extremely severe, including chronic hepatitis, which is a life-threatening fulminant form, or a carrier state where symptomatic individuals continue to transmit the virus. Let's talk about cirrhosis. Basically, cirrhosis is a progressive disorder defined by the extensive destruction of the liver. Tissue eventually results in liver failure. once 80 to 90% of the organ is lost. So this is frequently, the final stage of chronic conditions like alcoholic liver disease or chronic hepatitis. The pathophysiology involves a fundamental structural shift, where basically the functional hepatocytes are replaced by diffuse fibrosis and nodules of regenerated cells. This destroys the liver's organized lobular structure. Now, this fibrous tissue distorts the biliary and vascular networks as well, causing the bile to back up and blood flow to be obstructed. This can lead to portal hypertension, which is very, severe. Consequently, major functional losses can also occur, like basically including impaired bilirubin conjugation, reduced bile production, and a decrease in vital clotting factors and plasma proteins like albumin. Now, early signs, for example, are fatigue, weight loss, and a dull upper right quadrant pain. Even though they're vague, advanced signs are very severe. These include ascites, like fluid in the abdominal area, and then you have peripheral edema from fluid shifts, jaundice, increased bruising, systemic changes like spider nevi or gynecomastia due to impaired hormone inactivation. Diagnostics rely on liver biopsies to assess damage and serologic tests to monitor, for altered blood chemistry, such as elevated serum ammonia, especially. Treatment focuses on symptomatic support, including dietary restrictions and protein and sodium, uh, you know, restrictions, fluid management through diuretics or paracentesis, and medications like neomycin to control ammonia levels. In end-stage failure, post-portocable shunts or liver transplants may be required because the shunts are blocked completely. Critical complications include esophageal varices, maybe ulceration in the esophagus, which pose, massive hemorrhagic risk because those ulcers can, bleed, and hepatic encephalopathy. This is marked by confusion, asterexis, as toxins and accumulate in the brain, which is not a good thing. So let's talk about liver failure. When does this happen? This happens when approximately about 80 to 90% of the liver has been destroyed. This basically leaves the organ unable to perform its essential metabolic and synthetic functions. It most commonly develops as the end stage of chronic cirrhosis, now often caused by alcohol abuse or chronic hepatitis. It can also occur rapidly in fulminant hepatitis because that can lead to massive liver necrosis, destroying all, the tissue of the liver. Now, the underlying problem is the destruction of the liver's normal structure. Functional liver tissue is replaced by fibrosis and regenerative nodules. This can distort the vascular and biliary networks, leading to portal hypertension, impaired bile flow, progressive loss of liver function. Now, as a result, the liver can no longer produce adequate albumin, clotting factors, properly metabolize glucose, bilirubin, detoxify substances such as ammonia, or regulate hormone levels. Early signs include fatigue, anorexia, weight loss, anemia, and right upper quadrant discomfort. Now, as the disease progresses, patients could develop ascites, peripheral edema, jaundice, pruritus, hormonal imbalances, and increased bruising or bleeding. And this is due to the loss of the clotting factor production. Diagnosis is based on a liver biopsy, lab studies, and serologic testing, which could reveal elevated serum liver enzymes, increased bilirubin, elevated ammonia levels, electrolyte abnormalities, and prolonged clotting times like the PT, INR. Now, treatment focuses on supportive care and management of complications. Patients often require dietary modifications, diuretics, paracentesis to remove the fluid building up in the abdominal area, albumin replacement, which helps with the fluid shifts, reduce fluid shifts, and medications to reduce ammonia production. However, end-stage disease, a liver transplant remains the definitive treatment. Major complications include hepatic encephalopathy caused by ammonia accumulation, esophageal varices, ulcerations basically in the esophagus resulting from portal hypertension, hepatocellular carcinoma, and recurrent infections due to impaired immune function and fluid accumulation in the body. Now, together, these complications make liver failure a life-threatening condition and requires close monitoring and aggressive management. Liver cancer is a severe malignancy that can manifest either as a primary tumor, most commonly hepatocellular carcinoma, HCC, arising in the cirrhotic liver, or more frequently as a secondary metastatic growth from another site. Now, because the liver has a significant functional reserve, early symptoms are often minimal, right? You barely see them, meaning the cancer is typically well advanced by the time it's diagnosed, unfortunately. Initially, clinical manifestations are mild and general, including anorexia, weight loss, and enlarged liver, hepatomegaly, we call it. As the tumor grows, it disrupts the liver functioning, leading to portal hypertension, and enlarged spleen, and occasional rare paraneoplastic syndromes where the tumor cells produce substances mimicking hormones like insulin or estrogen. We talked more about the paraneoplastic syndrome in our cancer lecture, so please review that, to get a better understanding of how it, happens, what happens during that stage. Diagnostics primarily rely on imaging, such as CT scans and MRI, along with direct assessment through liver biopsies, serologic tests to evaluate liver function, such as ALT, AST. Then treatment options depend on the tumor stage. Localized masses may be, treated through lobectomy, removal of the liver lobe where the tumor is because it's localized, or radiofrequency ablation, while more widespread disease is treated with chemotherapy. Without successful intervention, the extensive destruction of the liver tissue can lead to systemic failure or metabolic functions and life-threatening vascular complications, such as esophageal varices and ascites. Now let's talk about acute pancreatitis. We see this in the clinical setting quite a bit. This is basically, it requires critical medical, treatment. It's considered a medical emergency, defined by basically inflammation of the pancreas resulting from autodigestion of its own tissues. This condition most frequently triggered by gallstones, which obstruct bile flow, or alcohol abuse, which stimulates increased secretion of pancreatic enzymes. The core pathophysiology involves the premature activation of pancreatic proenzymes, specifically the conversion of trypsinogen to trypsin within the pancreas itself rather than in the duodenum. Now, once activated, trypsin initiates an enzymatic cascade that triggers other enzymes like amylase and lipase. This leads to massive inflammation, tissue necrosis, and hemorrhaging. Clinically, it presents as a sudden, severe epigastric or abdominal pain radiating to the back and typically worsens when the patient is lying down. Patients may also show signs of shock, such as low blood pressure, hypotension, a rapid but weak pulse, pallor, like they look very pale, along with GI distress, like abdominal distension, a low-grade fever. Now, to diagnose acute pancreatitis, we usually look for elevated serum amylase and lipase levels, as well as hypocalcemia, low calcium. This occurs as calcium ions bind to the fatty acids in areas of the fat necrosis. Treatment is primarily supportive and focuses on reducing pancreatic stimulation by stopping the oral intake. Basically, patients are NPO, they're not allowed to eat anything. Managing intense pain with analgesics like meperidine and providing fluid and electrolyte support to stabilize the shock. If the inflammatory response is not contained, active enzymes can leak into the peritoneal cavity. This can cause chemical peritonitis. Basically, the peritoneum gets torn, right? This can lead to severe complications, including sepsis, adult respiratory distress syndrome, ARDS, and acute renal failure, contributing to a mortality rate of approximately 20%. Now, pancreatic cancer is an increasingly common exocrine cancer in, North America, notorious for a high mortality rate nearing 95%. It is primarily an adenocarcinoma originating from the epithelial cells of the pancreatic ducts. The most significant risk factor is cigarette smoking, though chronic pancreatitis and dietary factors also play major roles in this, development. Because the pancreas is located behind the stomach and has a significant functional reserve, the cancer often remains asymptomatic until well advanced, unfortunately, which frequently leads to a late diagnosis. The clinical manifestations depend heavily on the tumor's location. Those at the head of the pancreas typically cause an obstruction of the biliary and pancreatic flow, leading to early signs like jaundice and weight loss. And tumors in the body and the tail of the pancreas often remain silent for longer, eventually spreading to or involve nearby structures like the liver, stomach, and nerves, at which point pain becomes severe. Diagnosis usually relies on CT scans, though the disease is rarely found early enough for effective intervention. While surgical removal is possible for localized tumors, most cases are diagnosed at an inoperable stage, making clinical research trials the primary option for metastatic disease. Now, ultimately, early metastasis to regional lymph nodes and liver failure resulting from hepatobiliary obstruction are common complications and can often cause death in our patients. And that is it for our lecture on liver and pancreatic diseases. Next up is the lower GI disorders lecture.